Hello, good morning.
Good morning, Dr. Chan.
Is everybody here? Ada berapa orang patutnya?
Another one.
Seorang
Sorry,
lagi
another two.
Dua lagi.
Yeah, another
Okay,
two.
just tunggu 2 minit. Lepas tu belum pukul 10 lagi kan? Kalau diorang lambat, diorang lambat. Siapa yang tak ada lagi tu? Nama 2 orang yang tak ada lagi.
Not sure. Boleh tak? Ni ketua subgroup, can you check your subgroup members?
Tak apa, never mind. It's okay lah. Just wait until 10 o'clock. If they are not here by 10, just start without them first. Terus patutnya berapa orang?
Overall 27.
Including me, 28.
Yeah.
Okay. Can just start whenever you guys want to start.
Okay, so we shall start today's session. So, Assalamualaikum warahmatullahi wabarakatuh. Let's begin our session today with Ummul Quran Al-Fatihah. A very good morning. I greet to Dr. Chan and all my fellow friends. So today, our teaching seminar will consist of 4 presenters. I will be the first presenter with a topic of an overview, children with special needs. Next. So this is my outline. I will start with the definition, then epidemiology. After that, proceed with the types of children with special needs, evaluation of children with special needs, the goal of management, and also what Malaysia has done for these children with disability in Malaysia. Next. So let's go to the definition. Children with special needs. Our government has legally defined people with special needs or disability as those who have a long-term physical, mental, or intellectual, or even sensory impairment, which affect their daily function and effective participation in society. Next. Next. So
stop. Bye.
aku tak nampak skrin. Epidemiology, slide number 4.
Mushida, we're already in the epidemiology now. The slide is already at epidemiology.
Amin, who's the presenter? Oh, there. Who's the presenter, Amin?
I mean, just share the screen
I know who's the
because
presenter.
Murshida.
Rushida.
Murshida is the
What?
presenter.
I know where she. Wi-Fi dia lag ke?
Yeah, I think her internet connection is quite poor.
Okay, tunggu je eh. Let me wait for a
Yeah.
while. Rushida. Rushida. Ada tak? Muka tak nampak pun. Tak ada kan presenter? Hi Rushida, where are you? Nampak tak?
Doctor, can you see me?
Yes, okay. Can you continue?
Oh my
Okay.
god. Kejap doktor, kejap. My god. Come on. Okay. Epidemiology. Okay. Can you guys hear me? I hope so.
Yes.
So thank you. So for the epidemiology, previous slide, one slide previously. So what are the prevalence of people with disability around the world? Approximately about 15% of world population live with some form of disability. Why do we say approximately? This is because not all people with disability are registered. So that's why we can only approximate about 15%, which is quite a high number. And we expect the number is higher because of those who is unregistered. Okay. And out of them, 5.1% of the children around 0 to 14 years old have disability. This is reported by WHO. Okay. Next, in Malaysia. Okay. So in Malaysia, a total of 1.5% Malaysian population is estimated to be living with disability according to the UNICEF record data in 2014. And according to our social welfare department, it is recorded around 450,000 disabled people registered in 2012, while Ministry of Health reported that around 22,000 child with special needs registered from 2004 to 2014. So we can see there's a quite high number of people living with disability living among us. So we need to give extra care. That's why we need extra care and attention to them. Okay. Next. Okay. The types of children with special needs. According to our Ministry of Women, Family and Community Development, they divide or they categorize children with special needs into few categories, such as those with hearing impairment, vision impairment, speech and language delays, physical impairment, learning difficulties, even mental health, also included in special needs, those with disability, and also barriers. Barriers here means that the children have more than one types of special needs. Okay. So we go one by one. As for hearing impairment, it's basically a hearing disability where a person unable to hear clearly in both ears without hearing aids or unable to hear at all, even with the help of hearing aids. So causes of hearing impairment in children basically can be divided into two, which are sensory neural and also conductive hearing loss. Sensory neural, as you can see in the picture, usually involving our sense, vestibular cochlea, and while the conductive hearing loss involving the middle and also the outer ear. In sensory neural, it's usually uncommon and irreversible. It can be due to genetic, antenatal or perinatal infection like maternal vertical transmission, and hypoxic ischemic encephalopathy, any drugs, it can cause our sensory neural hearing loss. And usually the treatment of sensory hearing loss is by amplification, by using hearing aids, or even sometimes we can do cochlear implants. While for conductive hearing loss, it is a more common presentation in children. For example, in otitis media, sometimes they can come with effusion, or they can have a eustachian tube dysfunction. So the treatment of this conductive hearing loss, usually we give decongestion. If there is infection, so we give antibiotics. Surgery if needed. For example, we insert gormet if there is otitis media effusion. So hearing impairment in children or any hearing impairment can be categorized into severity too. So it can be divided into mild, moderate, severe, or profound. So in mild, in children, it is 15 to 29 decibel. While in profound hearing loss, it can they cannot hear up to 90 decibels. Okay, next. So for visual impairment or disability, basically they can be blind for both eye or one eye. If not blind, they can have limited vision or low vision in both eye or any other permanent visual disturbance. So what is low vision? Low vision is basically we define as vision less than 6 or over 8, but less than equal or less than 6 over 8, but better than 3 over 60. 3 over 60 is basically hand movement. As you can see in the Snellen chart on the right, 6 over 18 is in the middle, but 3 over 60 is hand movement. So if you cannot see hand movement, then less than hand movement, then we consider it as blindness. Okay. The causes of visual impairment in children can be divided into 3, which are genetic, antenatal or perinatal, and then postnatal. For genetic, they can have congenital cataract, albinism, and even retinoblastoma. While in antenatal and perinatal, they can get a congenital infection, infection to the eye, or even retinopathy of prematurity in prem baby, hypoxic ischemic encephalopathy 2, and also cerebral abnormality. As for postnatally, it can be due to trauma, like any trauma to the eye or any infection to the eye. Next, so how do we want to see this sign of visual impairment in infant? So we can see there is loss of red reflex. Sometimes instead of loss of red reflex, we can see leukocoria. So loss of red reflex can signify there is any opacification in the visual pathway. So any opacification of the lens or the vitreous. So we can see. So one of the reason that can cause loss of red reflex is like congenital cataract. And then if there is leukocoria, like in the picture down below, the red reflex is abnormal. Instead of we see red, we see white. So the causes of leukocoria can be due to retinoblastoma or retinopathy of prematurity and glaucoma. Okay. And other than that, according to Danvers development, we can say that babies at 6 weeks, they already have smiling responsively. So, but in babies with visual impairment, they does not smiling responsively even by the age of 6 weeks. They can also have like eye contact with parents. They have visual inattention. They have a random eye movement, nystagmus, sometimes squinting, and photophobia. So picture below, the boy in blonde is squinting. Okay, next. Okay, after visual impairment, is speech and language disability. So speech and language disability, basically inability to speak that impairs the communication or they cannot understood. means that it's two ways communication. They cannot say it and they cannot understand it. So by those who interact with the patient. So the causes of speech and language disability can be primary or secondary. For primary, like with babies with children with global developmental delay. So global developmental delay is basically any delay in two or more domains of the development that affecting children by the age of 5 years old. While secondary causes of speech and language disability can be due to hearing loss. So when they're unable to hear, they're unable to speak. And then also difficulty in speech production due to anatomical deficit, like maybe having any abnormality in the muscle that producing speech or sound, and also environmental deprivation means that maybe the surrounding of the children less talking, so they does not communicate oftenly. Okay, so speech and language disorder, it can be due to language comprehension, where they unable to understand or process the language, and also language expression, where they unable to produce the speech, and phonation and speech production, where sometimes kids can have stammering, also known as a dysphasia or gaga, and then dysarthria, where there is a motor that produce the muscle that producing speech have weakness, and also verbal dyspraxia, where there's also incoordination of the muscles or speech production. And also pragmatics. Pragmatics means here they cannot differentiate between sentence meaning and the speaker's meaning. Means that bahasa kiasan lah, ataupun any semantic, pragmatic and semantic disorder. And then for social or communication skill, usually patient with autistic spectrum disorder, they can have a social or communication skills disability. Okay. Next. Okay, thank you. For physical disability is a permanent inability of the parts of the body that caused by loss or absence or inability that affect the function. For example, as you can see in the picture of the baby with the absence of forearm and hands, this limb defect that is congenital, and then any spinal cord injury, any stroke. We also have childhood stroke, and also traumatic brain injury, and then dwarfism, or also known as chondroplasia, where it is defined that man less than 142 centimeter, while woman less than 138 centimeter. And the most common physical disability that we can see nowadays is cerebral palsy. Okay, next. Okay, now learning difficulties. So learning difficulties is means that any intellectual capability that does not conform with the biological age. So those which fall in this learning difficulties category includes in late global development, in children with Down syndrome, any intellectual disabilities, any learning disabilities such as children with autism spectrum disorder, children with ADHD, attention deficit hyperactive, and then specific learning disorder like dyspraxia, dyslexia, dyscalculia, dysgraphia. Dyspraxia is basically there is incoordination, and while dyslexia, as you can see in the picture up above, it is where the reading skill disproportionate to the children IQ. They sometimes have mirroring handwriting, and also dyscalculia. Dyscalculia, basically they have difficulty in calculation, and dysgraphia, where they have, as you can see from the picture, dysgraphic handwriting, they have problems in writing skills. Okay, next. as for mental disability, it is a state of severe mental illness that can cause inability to function in person, whether it partly or fully. So children, not only adults, children also can has organic mental disorder, which very rare, but it can have like schizophrenia, paranoia, or any mood or psychotic disorders. Okay. Next. Okay. After we know the types of children with special needs, now we want to know how do we want to evaluate these children with special needs. So basically, we need to investigate them, or we need to assess them as a whole, involving all the bio, psychosocial, and also spiritual last of them. And then, so medically, medical assessment, basically, we want to identify the cause of the developmental dysfunction, and we want to interpret or rule out any other medical condition that have a developmental impact, where by doing full, thorough history and physical examination, and also plotting all the growth chart and also the developmental chart. Okay, that one is for medical. While motor assessment, we do a comprehensive neurology examination, and we see this examination must be evaluated by specialists or therapists. Next. And then, okay, after medical and motor assessment, we need to also assess their psychological assessment by doing testing for cognitive ability. We also evaluate their personality and emotional well-being. We can do IQ and mental age score to these children. Other than that, we also do educational assessment, where we want to find out what is their weakness, what is their specialties. So after we find out their weakness and specialties, then we can develop individualized education plan. Okay, last evaluation is by social environment assessment. We also need to do home visit that can provide more comprehensive evaluation of the children. We can suggest additional adaptive equipment or innovation. For example, children with cerebral palsy, we can suggest them to use a wheelchair. And then if we suspect any neglect or abuse in the children, so we can refer them to a local protection agency. Okay. Next. So the goal of management of children with special needs is basically we want to maximize the children potential for productive adult functioning. We want to maximize their function. We want to optimize their function at our best. So basically, the first one is we need to treat the primary diagnosis. If the if the primary diagnosis is suitable, so we try our best to treat the primary diagnosis, and then we need to help the patient and family deals with the stress and any secondary impairment. Okay. Next. Okay. The last part. What our government have contribute in this children with disability in Malaysia. So early detection and intervention. Our Ministry of Health and Education already provide two good monitoring program. Where Ministry of Health already has health monitoring program from born until up to 6 years old by having this health record for babies and children, this blue and pink book, where from here we can detect earlier if there's any disability. But if we miss to detect during 0 to 6 years, then we can use the LINUS, which is introduced by Ministry of Education at 2012, where we detect children with disability that is undetected in early life. So what is LINUS? Next. LINUS is basically, next. Thank you. LINUS is basically literacy and numeracy screening. So we want to help in detecting children, especially those with language or speech disability, who are undetected in early on. So the students in the primary school are expected to know at least 3M, which are membaca, menulis, and mengira. So this 3M is being assessed every end of the years for 3 years in primary school. Okay. Next. And then other than that, our government also provide healthcare programs where we have government and also healthcare centers where we have trained occupational therapists, trained physiotherapists, and also social workers. Other than that, we also have community-based rehabilitation center, which can provide diagnosis, rehab, treatment, and also special and vocational training for these children with disability. Other than that, education, we also have special education school, or we call it as a sekolah pendidikan khas. Sekolah pendidikan khas for the children with disability. Other than that, we also have special education integrated program. The difference between special SEIP and also SES is that SEIP is a class of special education in a normal school. And other than that, we also have inclusive education program that is usually being done by the private sector. Next. Okay. We also have community-based rehabilitation, which each children with disabilities or needs, they can have allowance up to 50 ringgit per month, where this community-based rehabilitation provides therapy, provides social and help in language and social development of the children. They teach basic daily life skills, any reading, arithmetic and writing, and also recreational therapy and independent living training. Next, community, next. Next. Sorry. Community rehabilitation therapy, also known as PDK, ataupun program pemulihan dalam komuniti, which you can see from the picture on the far right, where the child is having a assessment for their height and other things. Next. Next. Okay. Okay, lastly, we also have social protection program. For those special needs that does not have support, we give this social protection program. It is they can have a cash allowance up to 150 ringgit monthly. It is provided by our Ministry of Education. The example of social protection program, or we can say asrama for these people, is Taman Sinar Harapan. It provides residence care and rehabilitation for children with disability. And then lastly, protection, legal protection. This legal protection. There are many legal law for people with disability, but with this legal law, we basically want to provide them good basic necessities, the right for them to live as a normal person, the right for them to have a job, the right of them to receive a healthcare. So one of the act that is related is the Child Act, which it covers 12 categories in children in need of protection. So including all the areas, it allows the authority, pihak berkuasa, to take over temporary custody or remove the child to a place of safety. If basically we want to protect the child right if there is any abuse. And then we also want to, they can also, the authorities can also remove a child to a place of refugee and rehabilitation if the child is deemed to be in need of protection and rehabilitation. So, yeah. Next, I think that's these are my reference. Do you guys have any questions? I'm sorry for the disturbance early on. I think if there's no question, the second presenter can take over. That's it.
So during proceed, dia dengar tak? Dengar, dengar. So let's proceed. So my title is mental retardation, which is not used anymore because it has been changed to intellectual disability, where mental retardation is replaced in DSM-5. So
Ana. Oh, Nur Ana Pitra. Now stop first. Don't go through mental retardation first. Rushida, just now I think your presentation cut out a lot because connection is not good, is it? Or was it just me? Did you guys hear it fully? Did everybody else hear it fully? Or did
Yes,
she cut
doctor.
out a lot?
We can hear her
Sorry?
fully. We can
Huh?
hear her fully.
You can hear fully.
Yes.
Because certain parts of the thing for me it wasn't full. Anyway, I mean, can you start from the beginning? Now, basically, children with disabilities, whatever Mushida presented towards the back, especially the support from the government and social support, that's what it's supposed to be, ideally supposed to be. But honestly, in Malaysia, the further you are away from the Klang Valley, the less resources you have, right? Min, let's go back to the last few slides. Tak payah beginning tu tak payah yang visual, hearing and those things tak payah. Before this a bit more before this. Now, okay, stop. Okay, obviously, evaluation of children with special needs, most of the time they get picked up in the community. So most of the time they get sent to the clinic kesihatan, then the family health specialist or the MO in the clinic kesihatan will see. Book, the pink and the blue book that all the kids have. Now, have you guys ever opened up that book? Yes or no? Have you ever looked at what's inside?
Doctor, can you repeat the question? The suara pecah-pecah.
I'm sorry, doctor, but you are stuck. We cannot get the question. Can you repeat?
Give me a while. Give me a while. My phone. Okay, so usually, have you guys ever looked at the blue color and the pink color book? What's inside actually? Yeah, tak pernah buka. Pernah buka tak buku tu? Do you know what evaluation is inside there? What the so-called evaluation for development for the kids? Huh?
regarding the growth of their growth.
Okay, what else? Okay, number 1, have you guys actually opened it before or not? Pernah buka tak buku tu?
Pernah.
That green,
Nah.
that pink and blue book. Pernah buka dan tengok betul-betul tak? Kau buka macam tu je, tengok immunization, lepas tu tutup balik.
Tengok
Tengok
anti-natural
immunization.
history dengan cross.
Okay. Okay, the next time you have that book, or the next time you go to the labor room, pinjam satu, lepas tu buka betul-betul tengok apa kat dalam tu. So basically they have charts, kind of like your developmental charts, where the nurses are supposed to take, you know, at certain ages, they have developmental milestones that the kids are supposed to reach, right? And the nurses are supposed to take during each well home visit. They also have that. They also have part of. They also have part of the autism screening template inside there. Which I can never remember the name. What's the name? Inside there, which they break it up to supposedly pick up. Yeah, they have parts of the MChat there also. Not the full MChat, but parts of the MChat to pick up signs of autism. But the problem with that is that it's dependent on the nurses doing the evaluation. A lot of times the nurses just ask the mom, okay, then right? Even the MChat is also dependent on the parents' level of awareness and acceptance that the child has a problem, right? Because if you look at the MChat, some of the questions about the MChat, right? I'm pulling up the MChat. If the parents don't think that the child has a problem, they are more likely to answer that the child, they don't think the child has a problem. You get what I mean? It's like, does your child answer to his name? That can actually be dependent on the parents. So if the parents keep on screaming the child's name, Karen, and then the kid looks once, and then the parents think that's normal, they say, yes, the child answers to me, right? But if you kind of do it once, and then after a while, the parents go back home and think about it, all right? Think about it. After a few days, they might change their answers, right? So that's why MChat is just a screening thing. Like, have you ever wondered whether if your child is deaf? That's one of the questions. If the parents are not aware, or the parents are working most of the time, and the kid is with the grandparents most of the time, they might answer no, right? Because they don't interact enough with the child. Does your child play pretend or make believe? Also, it depends on whether the parents play with the child or not. If they see the child playing with the car, then they might say, yes, the child is actually playing make believe. But if they sit down with the child for like 2 to 3 days actually observing the child, then they realize the child is actually not playing in the correct way, right? So it actually depends on the level of awareness of the parents regarding the problems of the child. The parents are in denial. Most of the time, they'll say that the child has no problems. You get what I mean, right? Right, so even the MChat is flawed in that manner. If you ask a person whose child was diagnosed with autism to take the MChat before and take MChat after, the answers will be totally different. Diagnosis. Now, motor assessment. Any doctor do it, right? Next slide. Next slide, Ami. Now, who's going to do all this? Mushida. Who's supposed to do all this?
Doctor,
Now, by right, yes, for cognitive ability. Right? 5 years, right, you guys?
Yeah.
Have you seen them being done? Yeah, by which department? By which
Psychiatry.
department?
Psychiatry.
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 How to get to psychiatry? How to get to psychiatry?
Differ from pediatrician.
Difficult.
It's like going through a whole marathon, isn't it? Isn't it? It's difficult, isn't it? Right?
Yes. Yes.
Okay. IQ, mental scores, evaluation of personality. A lot of times, a lot of doctors, especially if you are talking about anybody on the autism spectrum, they kind of push it. Mana see the child psychiatrist, which isn't the case with so, isn't it? Right? So a lot of kids don't get tested properly. Educational assessment. Where do you get this slide from, Mushida? Where do you get this slide from? What resources did you pull this from?
From Nelson.
Okay, so ideally this is what should happen, right? But in the real world, this doesn't happen, especially not in terms of Pahang. I'm not sure whether this happens, this gets done in KL. This probably gets done in KL and PJ, but privately, as in parents out of pocket have to pay, right? Even if you compare with the US, right, kids with learning disability, they get special allowances. Allowances not meaning money allowances, meaning time and effort allowances in school. They get a special helper in school, right? Those on the lower end of the milder end of the autism spectrum, they get help in school. They get somebody to follow them around school, see whether they understand their lessons or not. Malaysia, no, you don't even get that. You either get chucked into the pendidikan community, right, where the severe end of the spectrum and the the children who are severely disabled is, or you just get chucked into normal school without any help. All right, so by right, they are supposed to have an individualized educational plan. Once again, Malaysia, I don't see it happening. Not in Pahang at least, and not in places outside of KL and PJ, right? Home visits, I don't see any either. Suggest additional adaptive equipment or renovations. Also, I don't see. Now, a lot of it is limited because of resources, right? How much can the government side of it do, right? Because there's a lot of kids who are disabled, a lot of kids need help. Also limited by the parents' resources also. A child with disability, there's a lot of financial burden. The $50 a month they get, or $250 a month they get from the Jabatan Kebajikan, it doesn't help much. If the child requires proper physical therapy, like occupational therapy, the only way you can get frequent enough is by which frequent enough is actually once a week or once in 2 weeks, is to go private. To go private, one session is already $150. Okay, if the child needs speech therapy, frequent enough, ideally 2 to 3 times a week. One session is $150 privately. That's $450 a week. That's roughly about $2,000 a month, right? $1,008 a month. What normal middle to lower income, middle to low, and even low to middle, medium income families will have problems with that. How about the ones at the lower end of the finances? They cannot afford, and you cannot depend on the government. So, because the government are so packed, so they will get like an appointment once every 3 to 4 months. True, right? You see those kids in the government, they get appointments once to 3 to 4 months for speech therapy, which is inadequate. Obviously, you don't depend on the speech therapist only. The parents also have to do it at home. But if the parents are already struggling financially, you cannot expect parents to spend like 3 to 4 hours a day just interacting, doing proper therapy with the child, while you have another 5, 6 kids running around the house, another 6 mouths to feed, kids to send to school, schoolwork to be done, isn't it? Right? So the disabled children in Malaysia grossly under underutilizing whatever therapy. I mean, they're not underutilizing, they basically have no therapy, right? Okay, next, Amin. Next. How to help family and patient and family deal with stress? If if the parents are having trouble making ends meet, how to see the psychiatrist for the mother? Cannot, right? I mean, all these are all these are what is ideally should happen, but I'm just telling you it doesn't happen in Malaysia, right? Next. Okay. So the $150 a month doesn't do much, If the child really gets proper therapy, it doesn't do much. And if the child doesn't get therapy and the parents just use it for the child's daily expenses, it also doesn't do much, right? Hospital visits once a month, cab fare, grab car fare, $10, $20, loss of income for that day. If the child is not toilet trained, diaper. If the child cannot eat properly, need special milk money, doesn't really stretch much. I think a lot of you sit in Starbucks for like 1 hour between the 4 of you, you also blew off about $50 already, isn't it? More than $50, I think now. Right, so 150 doesn't stretch much. So next, mental retardation, which is a term that we shouldn't be using any longer, right? You guys know in Malaysia, you tend to use this term, but then you shouldn't because of the negative connotations associated with the word retardation. You guys know this, right? And Napitra, you're gonna talk about it now.
Yes.
Anna,
Yes, betul.
you're gonna talk about why we are not using the term mental retardation. Are you going to?
Mention that it will just replace into intellectual disability.
Okay, but why?
Why?
But why? Yeah, why?
About it. It was changed
Okay.
because of
Because of what? Because of what? Sorry.
What you have mentioned, the stigma for the mental retardation, the words retardation, where it is give a very negative, the stigma.
This is more. I mean, if you were in America, then they'd be really pissed off if you ever use this lah. But basically, because retardation is associated with very, very negative connotations, right? So last time, kids used to be, whenever whenever you want to insult a kid, the word retard is used, right? To mean that the kid is stupid or dumb, right? So at one point, so that word has been associated negatively. So whenever you use that word, you don't want the image of a negative image of the person to pop up in your brain, right? So you tend not to say this anymore, mental retardation. Okay, so as much as you can say intellectual disability, or even if you say impairment, it's slightly more acceptable than saying retardation. Okay, Anna Petra.
Dengar tak? Dah. Oh. So next. Dah next.
Dah kat list of content dah Ana.
Oh ya ke? So hmm. This is my list of content. Sekejap nanti. So, tak keluar lagi. So this is my list of content. We start with definition, etiology, history taking, physical examination, investigation, management, and then prevention. Next. Dah next ke?
Dah dekat definition.
InsyaAllah. Sorry doctor. So for definition, I took from up to date and also DSM. So for the up to date, it is a neurodevelopmental disorder that begins in childhood and is characterized by limitation in both intelligence and also adaptive skill. So for the adaptive skill, there are three domains, which is a conceptual, social, and practical, which at least need to be affected at least one of it with a varying severity. So for based on up to date, to diagnose ID, intellectual disability requires both limitation, which is intelligent also adaptive, with developmental onset before 18 years of age. So for the adaptive, where the intellectual disability children have a limitation in adapting, which affect their participation in multiple settings, such as in their home, community, and also school. And it is a very in severity that must be affected at least one of it. For the intellectual function, individuals with intellectual disability have limited in general mental capacity or intelligence, such as in learning, in reasoning, problem solving, abstract thinking, and also judgment. So intellectual function is correspond to an IQ or intelligent quotient, which is a two standard deviation or below the mean, which is where IQ score are usually less than 70 is considered as intellectual disabled. Next. Dah next tu.
Dah.
Dah. So for the DSM-5, it is also the same. Where it also require all three criteria, which is deficit in intelligent function, deficit in adaptive function, also the onset must be before during the developmental period, which is before 18 years of age. Next. And then for is it a slide of intellectual function?
Yes.
Yes. So for the intellectual function, where sorry. For the intellectual function, before IQ score was used to diagnose and classify disability. However, it was not used anymore. Because to diagnose intellectual disability, we require intellectual and also adaptive function. So for the children who have IQ less than 17, but their adaptive impairment is less, where because due to early intervention, we no longer the criteria is not met for the intellectual disability diagnosis. However, for the IQ level, it was as mentioned, it was 2 standard deviation below the mean, which is the mean is 100. So 2 standard deviation below, which is at 70. So level less than 70 is considered intellectual disabled. However, for assessment 2, which is standardized intelligence, is currently used by comparing the measured performance with expected for certain age. So the most commonly used is Bailey scale of infant development, where it was used for 1 month to 42 months of age. And then what the most common is a Wechsler scale, which is a Wechsler preschool and also primary scale of intelligence. Next. For the Wechsler preschool and primary scale of intelligence, it was as mentioned, it was by comparing the measured performance with expected of age. So Wechsler's preschool and primary scale of intelligence are used with a different range of age, such as the first table below the title for age 2 years 6 months up to 3 years 11 months, where they have a different domain in each question, with different for the age of 4 years old to 7 years and 7 months year old. Next. For the adaptive function, as mentioned, it has 3 domains, which is a conceptual, social, and also practical. But for the conceptual, the skills are basically the literacy, the concept of language, reading, and also writing. But for the mathematics, the concept of money, time, and number, and also for the abstract and theoretical reasoning, memory, also self-direction, and also judgment in a certain situation. While for the social domain, the skills included the interpersonal social communication, empathy, ability to relate to peers as friends, social problem solving, social responsibility, and also their self-esteem. Other than that, gullibility, the tendency to be persuaded or to be tricked, and also the ability to follow rules, and also and avoiding victimization. For the practical skills, it includes the personal care or daily living skills such as eating, dressing, mobility, and also toileting. And other additional skills such as following a schedule or routine, using a telephone, managing money, preparing meals, occupational skills, and ability in transportation or traveling, healthcare, and also safety. Next, for the assessment tools for adaptive function, the most common one is Wineland adaptive behavior, where it have the domains divided further into communication, daily living skill, socialization, motor skill, and also maladaptive behavior index. And other assessment tools is diagnostic adaptive behavior skill, adaptive behavior assessment system. Dah dekat severity ke?
Dah.
Dah. So for the severity, for the severity, is divided into mild, moderate, severe, and also profound intellectual impairment. While for the mild, their IQ level, as mentioned, I said that IQ score is not used anymore. However, IQ level is still used based on the standardized testing, where IQ levels for mild is between 50 to 55 and 70, where they require academic support and socially they have social skill and also personal judgment. However, they are immature. However, for practical, they are mostly independent. For moderate ID, their IQ level is between 35 to 40 and for 50 to 55. They may learn up to elementary level, however, need regular support and they have independent self-care with moderate support. For the severe, with IQ level between 20 to 25 and 35 to 40, they have a little understanding of a written language or number, time and money concept. They use very basic single words, phrases and gesture, and then for the basic action they need to be they need to be trained. For the profound, which IQ level less than 20 and 25, they may use object on goal directed fashion for self-care. However, cannot express verbally and they are mostly dependent. Next, for the etiology. So, etiology of intellectual disability are extensive. However, among the most known cause of intellectual disability is genetic abnormality. So, dah dekat. So for the etiology, it was divided into two, which is genetic causes and also environmental causes. For the genetic causes are divided into chromosomal abnormalities and also single gene disorder. For the chromosomal abnormalities such as Down syndrome or trisomy 21, having 3 copies of chromosome 21, or the Josh syndrome, a deletion at chromosome 22, Williams syndrome, microdeletion syndrome involving chromosome 1 through 11, Angelman and Prader-Willi syndrome, which both are deletion at chromosome 15, but with different inheritance, which is Angelman from the mother maternal side, or Prader-Willi from the paternal side. For the Smith-Magenis syndrome, is deletion at chromosome 17, Y4B3 syndrome, deletion at chromosome 5. So for the single gene disorder, such as it can be autosomal recessive or dominant or even X-linked. For the inborn error metabolism, it is autosomal recessive disorder, particularly occur in consanguineous marriage. And the one that I put the example is phenylketonuria. Then a fragile syndrome is X-linked disorder. Rett syndrome, mutation in MECP2, which occur exclusively in female. And the next, etiology for environmental causes. Further divided into prenatal, perinatal, and also postnatal. For the prenatal, the possible causes is intrauterine infection, such as torches, T for toxoplasma, O for others such as HIV, and then R, rubella, C, cytomegalovirus, H for herpes. And then drug injections such as phenytoin, mercury, and also alcohol. And then radiation such as exposed to the lead. For the perinatal causes such as preterm birth, infection, hypoxia, intracranial hemorrhage, and also trauma. For the postnatal, any accidental or non-accidental injury, CNS hemorrhage or malignancy, and then structural disorder such as tuberous sclerosis, for postnatal hypoxia such as near drowning, And for metabolic endocrine causes such as hypoglycemia, hypothyroidism. And then for psychosocial deprivation, neurodevelopmental disorders such as ADHD, autism. And then for mental health such as depression, also anxiety. Next.
Dah Hana.
Dah. Dekat Down syndrome punya gambar.
Ah.
Okay. So this is example for the chromosomal abnormalities. As mentioned, Down syndrome is trisomy 21. Yeah. So for their features such as hypothyroidism, obvious epicanthophore, low set ears, and then for and then DJOS syndrome, which is deletion at the chromosome 22, where they have cardiac abnormalities, abnormal facies, aplasia, cleft palate, and also had hypocalcemia and hypoparathyroidism. But for the Williams syndrome, microdeletion involving chromosome 1 to 11, where they have blue eyes with a starry pattern. Next. Next is Angelman and Angelman and Superdevili. Both deletion at chromosome 5. As mentioned, is the difference is Angelman is from the maternal side, while Prader-Willi is from the paternal side. However, both Angelman and also Prader-Willi, they have a mild to moderate severity of intellectual disability. Next. Next is Craig-Duquette and Smith-Magenis. Craig-Duquette, cat-like cry syndrome, where they have high pitches, cry resembling that of a cat. They also have intellectual impairment.
Anna, oh Anna, are you going to go through all the? Are you going to go through all the examples?
No.
No need to go through all the examples. I mean, your friends, you already listed down some. Your friends can read by themselves. Okay, just go through on. Go on. I mean, go on to next slide. Okay, Yani, start.
History taking. So for the history taking, generally we ask for gender first. As mentioned, there are some disorders have tendency in certain genders, such as for the Rett syndrome in female, or for the Fragile X syndrome in male. Then develop their developmental milestone and also level of functioning, able to function as a normal child. Then go to the birth history, basically to look for the causes. We ask for the antenatal, perinatal, and postnatal. And then beside birth history, to look for the causes, we also ask for the their nutritional history, any possible malnutrition, also their physical, any causes that contribute to their physical growth. And then for the past medical history of CNS infection, basically one of the causes of the that contribute to the intellectual disability. Then for family history, as mentioned that such as for autosomal recessive, particularly due to the consanguineous marriage, and then family history of intellectual disability or any family history of any syndrome, and then also ask for the social history. I mean how intellectual disability child affect their support, and then their financial, and then look for any mental health problem. And then relevant history by age. Parents may come with a concern with a different age child, such as a newborn. They may come due to dysmorphic features or microcephaly. Or for the early infancy, usually the parents will come with concern of failure to interact with the environment, or concerns about their child vision and hearing impairment. For the later infancy, about 6 to 18 months, usually due to growth motor delay. Usually the child cannot crawl, standing, or even walking. For the toddler, age 2 to 3 years, usually come with language delays or difficulty. For the preschool age, 3 to 5 years old, usually parents may come with language difficulty or delays, behavior difficulties such as play different play, such as no pretend play, and then in delay in fine motor skills such as coloring, drawing, or even cutting. And then for the school age, concern is due to the academic underachievement or behavior difficulties such as inattention, anxiety, or even having mood and conduct disorder. Next, for physical examination. For physical examination, first we try to look for dysmorphic features due to for the genetic and metabolic causes, and plot the weight, height, and if a patient has any syndrome, use a syndrome specific growth chart to look for any malnutrition or causes for short and tall stature. And then head circumference, any microcephaly, which is due to fetal alcohol syndrome or malnutrition, or even macrocephaly for neurological examination, hypotonia such as Down syndrome and also Prader-Willi syndrome, or even hypotonia for the eye examination such as cataract, where we can see congenital rubella, also hypothyroidism, and then a prominent eye such as in Fragile X syndrome, or even Prader-Willi syndrome, where we can see permanent eye. And then for ENT examination, look for any hearing impairment which directly cause the intellectual disability. And then for skin, look for any tuberous sclerosis lesion, such as hypopigmented or ash leaf neurokeratin. Then rash for the phenylketonuria or CNS infection such as meningococcal, and bruises for any non-accidental injury. And then assess a heart, lung, abdomen, genitourinary system, diet, and also extremities. And then assess for developmental milestone to look for any delay. Next, for investigation. Basically, the investigation, the goals is goals of evaluation is to identify a particular disorder in order to allow the clinician to provide more information to the family, basically for the prognosis and also associated condition. And then usually for the what we do is genetic study if it is indicated if there is family history of consanguinity, family history of multiple miscarriage or infant death, dysmorphic features, failure to track or stature abnormality, and for abnormal tone such as hypotonia, spasticity, and dystonia. Next is chromosomal testing. The most preferred is chromosomal microarray testing, which have a high specificity. And then for the metabolic studies, usually we use for the inborn error metabolism or other causes such as which they may present with episodic decomposition, seizure, failure to thrive, or abnormal neurological exam. Then for inborn error metabolism basic investigation such as taking serum ammonia, serum glucose, and serum lactate, blood gases, and also urine ketone, and also urine acid, uric acid. And then other than that, we also can do neuroimaging. The preferable neuroimaging is MRI rather than CT because CT can give radiation, can expose child to the radiation. And then what usually found on MRI is CNS malformation, any white matter abnormalities, or even cerebral atrophy. And then we can do electroencephalogram or EEG if we suspect any epilepsy or epileptic syndrome. Next is management. Specifically for intellectual disability, there is no cure. However, the goal of treatment is to strengthen areas of any reduced function, to provide ongoing family support, and to prevent or minimize further deterioration in child cognitive or adaptive function relative to peers, and then to promote optimal individual function in society. And there is no medication that is useful to treat the core symptoms. However, we can give supportive care and it must be individualized. The primary care for any acute condition that patient may come. And then we must involve all multidisciplinary unit, and then have a periodic re-evaluation. We must monitor the patient, have always follow up the patient. And then for the intellectual function, we give educational services such as referring to the kelas khas or kelas pemulihan. And for the leisure and recreational activity, we can refer patient to the physiotherapy and also occupational therapy. And then we must consult the family for their support and also mental health, and then treat for any associated condition such as associated in conditions such as ADHD, autism, or even other medical conditions. And next is prevention. So basically, prevention ke? So for prevention, for the primary prevention is basically to prevent disability by addressing the condition that may contribute to the intellectual disability, such as consanguineous marriage, try to avoid it, and then reduce prenatal alcohol intake, having a newborn screening for any metabolic disease, and then for the childhood to have complete immunization, and during the prenatal care, giving mothers adequate folic acid, and also prevent from being exposed to the lead. For the secondary prevention, it was directed in treating underlying condition to minimize the risk of impairment, such as for the dietary restriction or other intervention in children with treatable inborn error metabolism, such as restrict patient from eating meats, dairy product, beans or egg for the phenylketonuria, then thyroid hormone replacement of hypothyroidism, treatment of vision and hearing impairment that is associated with intellectual disability, the management of seizure and other coexisting medical disorder. While for the tertiary, it aims at minimizing function and also quality of life. Basically, we must identify early and give appropriate support services or resources, and then treat any comorbid or associated or existing condition, And then we must establish an accurate diagnosis. And for the unknown causes, try to evaluate for any genetic causes. Next. Last one. Oh, I forgot to mention. But for the infant and children less than 5 years old, we did not use intellectual disability as a provisional diagnosis. However, we use global developmental delay until we can use the standardized testing to be completed accurately and reliably. So basically, usually after 5 baru kita boleh guna we can use intellectual disability. That's thank you. Any question? Doctor?
Yeah. Hello. Anything you want to ask? You guys could hear my kids, is it? No. You guys could hear what my kids are watching, is it?
Yes.
Okay, sorry. Huh? Yeah. Sorry about that. I'm in the kitchen, the outside. Okay. Nothing much because actually all 4 topics today, it's mainly just good for you guys to know. It's just general knowledge. So you can go on to the next one.
Okay, so next, I will present about the adolescent health problems. Okay, next. So basically, these are the outline. So I will talk about the introduction, assessment by using heads, and range of health problem that will be briefly discussed is 6, chronic illness, somatic disorder, mental health problem, eating disorder, health risk behavior, and also menstrual problems. Okay, next. Okay, so adolescent. So what is adolescent? Basically, it is the transition between the children and adult. However, there are no specific range given. But according to WHO, adolescent is a person who is from the age of 10 to 19 years old. And it can be divided into early, mid, and late adolescent. And it can also be divided according to biological, psychological, and also social. Okay, next. Okay, for the epidemiology, the all-cause mortality is reducing from 1990 to 2013, so about 23 years. From the age of 10 to 14 years old, we can see there is a reduction of mortality from 38.2 to 21.4 per 100,000. And for the 19 and for 15 and 19 years old, from 87.5 to 59.6 per 100,000. And for the cause-specific mortality are different based on gender. For male, it's basically due to road traffic accident. And for female, it is due to non-communicable disease, in this case, neoplasm. For history of self-harm and opioid use was low to cause mortality. Okay, next. Okay, so basically these are the table. 2013, the mortality rate of male and female. So as you can see, male, motor vehicle, female, neoplasm. Okay, next. Okay, next. Okay, so for the epidemiology, it can be said that there are top 5 leading cause of death in adolescent. The data was taken in 2007. So as you can see, the rank 1, 2, 3, 4, 5. The first one is unintentional injury. Second one is homicide. Third one is suicide. Fourth, cancer. And also 5, disease of the heart. Okay, next. And as you can see, for the National Vital Statistic 2019, so after 12 years, the number one is still unintentional injuries. However, the rate have gone down from 30.3 to 16.8. The second rank, previously homicide, now becomes suicide. The third one, homicide. Fourth one, malignant neoplasm. And lastly, disease of the heart. So basically, as you can see in 2007 and also 2019, for the top 5 rank of leading cause of death in adolescent is the same. However, the causes of number 2 and number 3 is switch place lah. Next. Okay, so for the assessment of adolescent, to make it simple, we can use the HEADS approach. So HEADS. So H is home. So home, what are the questions that we can ask to the patient is, where do they live? What do their parents do? How about their siblings? What are their relationship with their parents and the siblings? Is it good? Is it bad? Are their parents divorced or not? Okay. For the education, what grade are they in? How are their performance in the school? Do they skip schools? Are there any case of bullies in the school? And how about their relationship with the teachers? Okay, for the employment, whether they are part-time or full-time, and why? Because in adolescent, we expect they are to be at the school, not working. So if they are working, then how? And why? Why are they working? Okay. For the eating, E. So if there any change in diet, or change in body shape, maybe they dislike their body figure. For activities, what are the type of activities that they usually do in their leisurely time? Is it sedentary lifestyle, or are they involved in gangs? So in this activity, we need to ask also what type of activity that they usually do and what kind of friend that they make. Okay, for the drugs, D. Okay, so is there any drinking or smoking history? And if they really do drugs, what type of drugs and what is the frequency? Okay, for the sexuality, we need to talk about any history of intercourse. And if yes, are they involved in multiple partners or just single partner? And do they know regarding the knowledge of any sexually transmitted disease, STD? And for female, we need to talk about their menarche and also ask regarding self-examination for breast, and for male, self-examination for the testicular. Okay, next S is suicide or depression. So we need to ask the patient whether they are feeling low mood or there is changes in the sleep or appetite, and is there any history of self-harm in the patient. And last S is safety. So if there any violence at home or there are invites, or is there any history of fights at school? So how are their safety? Next. Okay, so I will talk about the health problems. So in this case, there are 6 that I mentioned earlier: chronic illness, somatosome disorder, mental health problem, eating disorder, health behavior, and also menstrual problem. Okay, next. Okay, so for the chronic illness, the example that can be given are asthma, epilepsy, diabetes, cerebral palsy, juvenile idiopathic arthritis, and also sickle cell disease. So what are the problems that are faced by this patient is that the first one is adherence, which are the balance between illness with social life, and the balance are worse by lack of knowledge. Biological, if the patient has any delayed puberty or short stature, which if in case of short stature, they might be bullied in the end. Okay, for psychological, less mature behavior, sick role, lack self-esteem, and also depression. And for the social problem, they can experience reduced independence, failure of peer relationship, social isolation, school or social event absent. Okay, next. Okay, for the second one, somatoform disorder. Okay, for somatoform disorder, it is a physical symptom that suggests illness or injury. but cannot be explained by general medical conditions, substance, or mental disorder. So usually the typical symptoms that are presented by the patient are fatigue, headache, abdominal pain, backache, and also dizziness. So what are the examples of somatoform disorder? Somatic disorder, illness, anxiety disorder, and also conversion disorder. Okay, so next, somatoform disorder are also common in adolescents. And for somatoform disorder, we must exclude any organic diseases through history, physical examination, and also investigation before we can say that is somatoform disorder. And somatoform disorder can also be precipitated by bully or family problems. And if the disease is too severe, it can also impair the quality of life of the patient, such as the attendance to the school, drop in academic performance, and also social. Okay, next. Okay, for mental illness, so it is said that over half of all cases of mental disorder begin by age of 14, and the majority remain untreated well into adulthood, WHO 2014. So we can say that mental illness start early, and usually they are not treated well, so the symptom persists throughout their life. Okay, for example of the common mental illness is anxiety disorder, depressive disorder, disruptive disorder, and also ADHD. Okay, so what is the one of the worrying concern about mental illness is the patient can also present with self-harm, and it is thought to believe that why they do this self-harm because they want to feel relief from feelings or thoughts, they want to punish themselves, or they want to get someone to know, to get a reaction, and they want to get attention from someone. Some of them want to die. Some of them because of being unhappy, depressed, and lastly, self-harm can be also due to method of coping, bad coping lah basically. Okay, next. Okay, for the eating disorder, so eating disorder happen due to the patient dissatisfaction of their body. About 40% female and 35% male begin dieting. Example of the common eating disorder is anorexia nervosa and also bulimia nervosa. Okay, most adolescents who develop eating disorder did not have obesity, but some adolescents might misinterpret what healthy eating is and engage in unhealthy behavior because they feel dissatisfaction to their body, so they want to eat healthy, but they misinterpret what healthy eating is, so it become a eating disorder lah. And the peak age for onset for anorexia nervosa is mid-adolescent, and peak age of onset of bulimia nervosa is late adolescent. Okay. What are the complications of eating disorder is hypothermia, bradycardia, electrolyte imbalance, and also amenorrhea. So these are the things that we need to watch in this patient. Okay, next. Okay, the fifth problem that I want to talk about is the health-based behavior, aka risk-taking behavior or high-risk behavior. So the patient do health-risk behavior because they are looking for pleasure and excitement in new experiences, and they want to feel independent from parent or as an act of rebel. Because we know that in the adolescent period is a time where they want to know oneself and want to get acknowledgement from others. So basically ada peer pressure and peer pressure. So maybe this is what contributed to the health risk behavior. Okay. And then why they do this health risk behavior is because they lack of knowledge about the consequences. Example of health risk behavior is smoking, drinking, drug abuse, and also sexual promiscuity. And why our concern in health risk behavior is it is usually continue to adult life. And if it's not treated early, then it can become a habit. So it will become a big problem later in life. Okay, next. Okay, and last but not least, menstrual problems. So it occurs about 75% in adolescent female. So the patient can be presented with delayed onset of menstrual problems, amenorrhea, irregularity, heavy flow, or dysmenorrhea. It said that the average menarche is around 12.5 years. And the usual menstrual cycle initially longer, up to 45 days, and become regular after 3 years, which is 21 to 35 days. And the normal duration of menses is 7 days or fewer per cycle. And the normal blood flow is 6 soak packs or tampons or fewer per day. So if there is any changes in this blood flow or duration of time, or they are experience any pain, then we can call that as a menstrual problem. And that's all from me. Next is the reference. Any question?
Anything you guys want to say? I want to ask.
Sorry, Ada?
Anything you guys want to ask?
I think no. So can we proceed to the next presenter, Dr.
No questions, then proceed to the next one.
Okay. Thank
So
you.
can you hear me clearly?
Yes, Amin. We can.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh, and a very good morning to Dr. Chan and fellow colleague. Allahumma salli ala Muhammad wa ala ali Sayyidina Muhammad. Now we already reached to the end of the presentation. Okay, I'm going to talk about an interesting topic entitled palliative care. My name is Shamil bin Sanusi. Okay, next slide. So this is an outline of my presentation. I'm going to talk about the definition, goals, indication and principles in palliative care, and as well as the management and also end of life care. Next. Okay, so according to World Health Organization, palliative care for children is defined as an active total care of the child's body, mind and spirit, and also involve giving support to the family. It begins when illness is diagnosed and continues regardless of whether or not a child receives treatment directed at the disease. So the keyword here is palliative care is a total care, and not only to care for the patient, but you also to give support to the family, and it considered as a continuous care. Okay, next slide. So the goals in palliative care, first and foremost, is to improve the quality of life. We want to ensure that patients having a meaningful life despite the disease is curable or not. Second is to maintain the dignity of the patient and the family members. Third is to ameliorate the suffering of the seriously ill child. Next. So, what are the indications of palliative care? Meaning, who needs palliative care? So, the first one is when a cure is possible, but failure is not uncommon. For example, with patients who have cancer with a poor prognosis, such as cancer of acute leukemia, brain tumor, or osteosarcoma with stage 4 that already maps to multiple organ. Second is for long-term treatment with the goal of maintaining quality of life. The examples of disease for this indication are cystic fibrosis, HIV, chronic immunodeficiency, chronic or severe respiratory failure. So in cystic fibrosis, especially when it already progressed to become advanced lung disease, it requires pulmonary rehabilitation, nutritional support, and as well the continuous antibiotic therapy in order to prevent recurrent chest infection. Third treatment that is exclusively palliative after the diagnosis of a progressive condition is made. For example, in the case of trisomy 13 syndrome or Patau syndrome, because we know that in Patau syndrome, they can be presented with severe neurologic and physical defect. So this opt them to go into a palliative care, or in the case of severe form of osteogenesis imperfecta. Osteogenesis imperfecta is considered is known to be a brittle bone disease, so they can be presented with um, so palliative care is indicated in order to prevent recurrent bone fracture or to prevent any long bone deformity occur in future. So number four is when the treatments are available for severe non-progressive disability in patients who are vulnerable to have complications such as in severe spastic quadriparesis with difficulty in controlling symptoms, or in the case of severe brain malformation such as AV malformation. Next. Okay. So what are the principles in palliative care? So the first one is to give respect for the dignity of patient and families. Second is to give access to comprehensive and compassionate palliative care. Third, the use of interdisciplinary resources. For example, like managing a case of, for example, it might involve the clinician in managing the physical symptoms, and it also can involve the social worker to cater the psychosocial support of the patient. And fourth, to give acknowledgement and support provision for the caregivers. And fifth, to give a commitment to quality improvement of palliative care through research and education. Next. Okay. So next is hospice care. So what is hospice care? It is considered as a treatment program for the end of life. It provides the range of palliative care services by an interdisciplinary team. So those who can receive hospice care are a patient with a prognosis of death within 6 months, or when the cessation of curative efforts for children is indicated, and third, for curative efforts to be continued, while the higher level of coordinated end of life service may be applied. Okay. So basically, palliative care, hospice care is started when the palliative care teams believe that the ongoing treatment is no longer helping. So it's similar like in palliative care, but then in this hospice care, there is an attempt to cure the person. The person's illness are stopped. So there's no any more attempt to cure the person illness at this stage. Next. Okay. So bereavement. I'm going to talk about bereavement next. I think we already learned the definition of bereavement and grief during psychiatry posting. So bereavement is considered as a process of psychological and spiritual accommodation to death, whereas in grief, it is an emotional response caused by a loss, including pain, distress, and physical and emotional suffering. Um, So it is a difficult issue for parents actually to talk to their child about the child's imminent death. And usually parents tend to regret more when they don't talk about the child's death rather than having done so. Because to talk about the conditions of the children's might help the children to understand their condition either physically, emotionally, and spiritually, that help to facilitate their comfort and reduce their anxiety. And I'm going to explain later on what are uh, the response or the strategies for the parents to talk to their child according to the child's age, because different child's age have different understanding about death and the illness. Next. Okay, now I'm going to talk about the cognitive issue in children and adolescents, understanding death and dying. Next. So for very young children up to 2 years of age, they still don't have the clear understanding about the concept of death. So usually they tend to have to just show an associated behavior of protesting and difficulty of attachment to other adults who take care of them. And then the degree of difficulty depends on the availability of other nurturing people with whom the child has a good previous attachment. Next slide. Okay, so during this age, so the typical question and statement about dying usually they would they will mention like, "Mommy, don't cry. Daddy, will you still tickle me when I'm dead?" And then their thoughts that guide the behavior is they have a limited understanding of the event, like I mentioned just now. They don't really have clear understanding about death, and so the developmental understanding of death, the child might have sensed that something is wrong. Death is often viewed as continuous with life, which is an analogous to being awake and being asleep. So it's just a continuous with life. So the strategies and response for the parents or the clinician is to optimize comfort and consistency, meaning that to provide a familiar person, objects or routine, and then use soothing songs, words and touch. For example, I will always love you, I will always take care of you, and I will tickle you forever. Next slide. Okay, so for the pre-operational state that occur in children from 3 to 5 years of age, um, they tend to have trouble grasping the meaning of the illness and the permanence of the death, and their language skills at this age make understanding their moods and behavior is difficult, and they tend to consider death as a punishment, and sometimes they can feel overwhelmed when confronted with the strong emotional reaction of their parents. Next slide. So the typical statement for this particular age of children, they will tell like, I did something bad and so I will die. Can I eat anything I want in heaven? And then the understanding about uh, their understanding towards their behavior is that they believe uh, that the concept are simple and reversible, and variation between reality and fantasy. And the understanding about death is that they may see death as temporary and reversible and not universal. And child may feel responsible for illness. Death may be perceived as an external force that can get you. So the strategies and response that the parents can do for this age of child is to assure child that illness not her fault, and provide consistent caregivers, promote honest, simple language, use book to explain the life cycle and promote question and answer. For example, you did not do anything to cause this. You are so special to us and we will always love you. And we know that God, grandma or grandpa are waiting to see you. Next. For the late pre-operational to concrete operational stage, which occurs during 6 to 11 years old, so they gradually start to understand the concept of death, and then the magical thinking gives way to a need for detailed information to gain a sense of control. And then older children in this range have a strong need to control their emotions by compartmentalizing and intellectualizing. Next. So at this age, they usually like mention, how will I die? Will it hurt? Is dying scary? And then they begin to demonstrate organized logical thought. Thinking become less esoteric. Child begins to problem problem solve concretely, reason logically, and organize thought coherently. However, child has limited abstract reasoning, and their understand about death is that death is real and permanent. So they understand that death means that your heart uh, stops, your blood does not circulate, and you do not breathe. Um, so the strategies that the parents can use is to be honest and provide specific details if they are requested, help and support the child's need for control, permit and encourage the child's participation in decision making. Okay, so you can use this sentence like we will work together to help you to feel comfortable. It is very important that you let us know how you are feeling and what you need. We will always be with you, so you do not need to be afraid. And finally is a formal operation stage that occur at the child more than 12 years of age. So they already perceive that death as a reality, as a universal event, and it is irreversible. And at this age, the adolescents handle death issue at the abstract or philosophical level and can be realistic. And they avoid emotional expression and information, instead relying on anger or disdain, and their wishes, hopes, and fears should be attained to and respected. Next slide. So at this stage, they tend to uh, tell like, I'm afraid if I die, my mom will just break down. I'm too young to die. I want to get married and have children. Why is God letting this happen? And the thoughts that lead to their behavior is that they have an abstract thought and logic possible, and then child's need peer relationship for support and for validation. Child express altruistic values. What does it mean by altruistic value is that is an unselfish concern for the welfare of others. So yeah, example is I want to stay alive for my family, my parents, my sibling, and I want so start to think of donating organ or tissue and disbelieve that she is dying. So like I mentioned that they understand death as irreversible and universal. So at this stage, the parents can reinforce child or adolescent self-esteem, a sense of worth, and self-respect, allow need for privacy, independence, and to access to their friends and peers, tolerate expression of strong emotion, and permit participation in decision making. So you can use the sentence like, I can't imagine how you must be feeling. Despite it all, you are doing an incredible job. I wonder how I can help. What most important to you now? What are your hopes? What are your hopes and your worries? You have taught me so much. I will always remember you. So those are the sentences that the parents can use. Okay. So next. So I'm going to talk about the elements for palliative care. Next. So there are three elements. The first one is pain management. Second, expertise with feeding and nutritional issue. Third is management of symptoms, which consists of five common symptoms in palliative care to manage, which are nausea and vomiting, constipation, dyspnea, fatigue, and also delirium and agitation. So next. Okay, for the pain management, it's important to identify pain and assess its severity. And the goal is to of the treatment is to eliminate or reduce and as well prevent the pain. And usually we use a WHO analgesic the approach, and it's very important to avoid unnecessarily painful procedure to the patient. And we should use adequate dose of analgesic uh, by by the clock principle that we mentioned. I will explain later. And sufficient dose and appropriate pharmacological formation is needed. And then yeah, appropriate dose is the dose that effectively relieve pain. So these are very important in order for us to make sure that the child have a good quality of life and doesn't have to wake up at night because of pain. Next. Okay, so this is the WHO analgesic letter for pediatric. Okay, as you can see, for step one, if patient have mild pain, usually we give a non-opioid. Okay, non-opioids such as ibuprofen or paracetamol for age more than 3. If age less than 3, we just give paracetamol because we know that ibuprofen has a poor GI safety profile, so we try to avoid in the younger children. And then we can also plus minus adjuvant such as antidepressant, anticonvulsant, antispasmodic, muscle relaxant, biphosphonate or corticosteroid. And then step up if the pain persists or increase. For patients who have moderate or severe pain, we can give strong opioid, for example, morphine or fentanyl or oxycodone, hydromorphone or buprenorphine, plus minus non-opioid and also adjuvant. Okay, so about the dose by the clock, it's mentioned here like time doses based on drug half-life. You can see at the bottom in the box. So meaning that doses by clock, that meaning that we should give the medication before the end of the half-life of the drug. For example, like morphine, they have approximately 2 hours of half-life. So before the end of the 2 hours, we should already prepare for the next dose of the drug to prevent future pain. Okay. So it's also mentioned that consider prophylactic laxative to avoid constipation because opioid can also induce constipation. So I've read that we should consider to give laxative to prevent constipation in patient. Next. Okay, next is expertise with feeding and nutritional status. So in some setting, enteral or parental nutrition may be considered depending on patient condition. So a few points to be considered is um, should identify intervention that may improve the anorexia and cachexia. And then review the potential adverse effect of the enteral nutrition, including nausea, vomiting, aspiration, or any oral secretion. And then review that children can live comfortably for long periods of time with minimal fluids and nutrition. Next slide. Now we go to the management of the symptoms. So we should recognize the symptom and assess and do proper assessment, including the psychological, social, spiritual, and physical symptoms. And the core principles of symptoms management, first is to treat the underlying cause. Second is to give a drug, behavioral, physical, or supportive therapy. Third, persistent symptoms we should treat with regular interval medication. Fourth, severe and uncontrolled symptoms should be regarded as medical emergency. So patient should be referred for active intervention, and then avoid inappropriately invasive and painful routes of drug administration. And then side effect of medication must be anticipated and actively treated. Next. So we go for the first symptoms. The common symptoms is the first one is dyspnea. So it can be due to the pulmonary disease itself, like pneumonia or cystic fibrosis. Can be due to anemia or airway obstruction from tumor metastasis or heart failure from cardiac disease. So for the management, we can give morphine, as it can give immediate release to the dyspnea. So for the morphine, usually we give uh, low dose. And why we give morphine? Because it have a short acting. So low dose might can prevent from patient getting any respiratory depression. And then suction secretion if present, comfortable loose clothing, fan to provide cool, and then behavioral strategies including breathing exercise or lorazepam if it's associated with anxiety. Next. Okay. So the second symptoms is nausea and vomiting. So it can be due to the side effect of the treatment such as radiotherapy or chemotherapy, opioids or NSAIDs, or it can be due to the constipation itself that causes nausea and vomiting. So for the management, if the medication known to cause the nausea, vomiting, so it may be necessary to discontinue or replace the medication. And then we should prevent the constipation by giving laxative. And if patient, we can also consider to give anti-emetic like metoclopramide. And also because we know that one of the complication of vomiting is patient can get electrolyte abnormalities like hypochloremia, hypokalemia, hyponatremia. So we should manage the electrolyte abnormalities. Next. Okay, so constipation is common in a patient with a terminally ill patient. So it can be due to immobility, weakness, or poor oral intake, and it can be due to drug. So for the management, uh, we should encourage increase in fluid intake and increase fiber in diet. Okay, we should consider giving anti-emetic if the nausea is one of the that cause the patient to have a constipation, and then constitutive laxative like lactulose or bisacodyl. Next slide. Okay. So the next symptoms is fatigue. It can be due to anemia, infection, pain, impaired nutrition, sleep disturbance, depression, anxiety, and also medication. So for the management, we should address and treat the anemia by ensuring that patient get enough nutrition, or with severe anemia, we should consider for blood transfusion, and then use of psychostimulant like methylphenidate, because methylphenidate can increase wakefulness, and then treatment of depression, anxiety, sleep disturbance, for by giving SSRI or together with the benzodiazepine, and then encourage gentle and regular exercise. Next slide. So I'm going to talk about end of life care next. So end of life care is basically the management of end of life symptoms. It should be an ongoing preparation and support to the patient and as well the family members. And at this point of time, we should start to discuss about preferred location of selection or of a preferred location of death, a discussion of autopsy or organ and tissue donation, and also we should provide bereavement support and counseling to the family members. Next. So I already reached the end of the content. So I'd like to share this quote by Patch Adams. He is an American physician and as well a comedian. So he mentioned here that you treat a disease, you win or you lose. But if you treat a person, I guarantee that you will win no matter what the outcome. So it's very important for us not to only treat the physical symptoms of physical disease, but also to also cater the emotional, mental, and also spiritual needs of the patient, so that we can provide a holistic approach to the patient. So these are, okay, next slide. So these are my references. Thank you very much. Is there any question?
Okay, there are two videos. It's actually one video on credit card, and then the other one is a bit longer. The first video is about 5 minutes, the second video is about 30 minutes. Just watch the 5 minutes one if you have no time. If you have time, then you can watch the 30 minutes. The 30 minutes one is the Singapore one. I think it's a whole series, but it's quite nice. I'll link it Okay, so there's two links in the chat. If you look in the Zoom chat there, there's two links there. Just copy the links before you leave the group chat lah, okay? And then just watch them lah. They are both 5 minutes long. The Singapore one, I think it's a whole series actually. So if you feel like watching, you can watch lah. But I think with regards to palliative care, they're quite informative. Okay. So any questions or not? If no questions, then we can just end. No, tak ada. Tak ada. Kalau tak ada, just tanya.
Thank you, Doctor.
Thank you, Doctor.
I give your grades to Farah. I mean the admin, or do I give the grades to you, the speakers? Hello. Hello, everybody.
Hello.
Guys, ada jawapan. Hello.
Dr. Chan, I
Cakaplah
think
sesuatu.
you can just give to Anna, the one that contact you. But we
Am I
need
on
to
mute?
get
No.
your.
You guys can hear tak?
Hello.
What's happening?
Yes, we can, Doctor.
Hello.
Oh, hi. Sorry. I accidentally put you guys on mute. That's the problem using the phone. Okay, so do I give your grades to the admin, or do I give the grades to you?
You can just give the grade
I-
to Anna, the one that can contact you. But we need to get your signature at the logbook.
How are you going to get a signature in my logbook? The next session with you is also it's also a lecture, right? Right, I'll just give it to Farah. I'll give it to the admin. I don't know what to do because it's on online thing, isn't it? Right?
Okay, Doctor.
Yeah. So it was anyway, she has a list lah. So remember to watch the videos. It's only 10 minutes. And then okay, that's it lah. Okay. Okay, bye guys.
Thank you, Dr. Chan.
Thank you, Doctor.
Thank you,
Thank you,
Doctor.
Copy the link before you guys leave.
Yeah, we already
The
shared
YouTube
to the
link
group.
before you guys leave. Okay. Bye.
Thank you, Dr. Chan.